Good evening, everyone. I am very, very happy and excited to be back with all of you. And I do hope that you had a nice and relaxing weekend, Easter weekend. And I am also very happy that we have another special guest. And again, this is Dr. Alejandra Aguilar Crespo. And I'm very, very happy to have you here with us tonight. How are you
Thank you.
feeling today?
Thank you. Very fine. And you, Caroline?
I am very well, and I'm very, very, as I've mentioned, excited because we
Yes.
had a week break
Mm-hmm.
when it comes to those webinars. So
Yes.
I am very glad that we are back with some more events. And as you know, there is another week's coming up with different topics, with different experts. So thank you so much for joining us once
Thank
again.
you.
Dr. Alejandra, it's great to have you, that's for sure. And today, as you can see, we do have an interesting topic, hormonal
Mm-hmm.
factors that may affect fertility. And as always, just let me briefly tell you that we will start with Dr. Alejandra's presentation, but afterwards, remember, it will be time for your questions. So as always, just put those in the chat section and Dr. Alejandra will help you out with those, no doubt here. And well, remember that, as I've mentioned, we will be here every single day. And we meet here almost for, I think that we already had, yeah, we had over 300 IVF webinars. So if you go to our
Wow.
website, myivfanswers.com, you can find all those previous webinars there. And also, I want to mention that Dr. Alejandra already had a few with us. So
Mm-hmm.
so you can also check her previous webinars on different topics. And my IVF Ancestors is also a part of European Fertility Society, and we are very proud to be able to support you, to answer your questions, to give you an opportunity to simply meet the top fertility experts like we have one today. And with that, that will be it from me. And let's go with the presentation, okay, Dr. Alejandra?
Thank you, Caroline.
Excellent. Let's go.
Okay, so good evening, everyone. It's a pleasure for me to attend this webinar. And today we will talk about hormonal factors that may affect fertility. Okay, it's very important to understand that when we face a couple with a history of infertility, there are several factors that we have to take into account. Okay, it is known that the age of the woman is one of the most important factors that affects the results of the cycle. But it is true that there are also other factors that plays a vital role in the treatment, and we cannot forget. And these are the hormones, okay, the hormonal factors. Well, the endocrine system is very important for the regulation of pregnancy, and it's very important to understand that the ovulation is precisely regulated by hormones, and any imbalance of this can provoke infertility or alterations during the menstrual cycle. When we study an infertile couple, one of the first things that we have to do in a first consultation is to evaluate the basal hormones, okay? If there is any alteration, it is mandatory to treat this alteration in order to improve the results. Well, when we are treating a couple with infertility, we have to ask for basal hormones, and we have to study several hormones of the different axes that we have. Here we will focus in women's infertility. Okay, so it's very important to understand which are these axes. Here in this graph, you can see that we ask for the ovary and hypothalamus and axis, which is the FSH, LH, estradiol, progesterone, and anti-Müllerian hormone. We will ask also for the prolactin, thyroid hormones, the insulin, androgens, and the vitamin D. Okay, and later we'll explain a little bit that. There are some hormonal disorders that can provoke infertility, and today I will talk about these hormonal disorders. The first and most frequent hormonal disorders is the polycystic ovarian syndrome, PCOS. It's defined by a hormonal imbalance. Okay, it's caused by a hormonal imbalance and is a multifactorial entity that can affect 10% of women of reproductive age. It is a metabolic disorder in which the woman generates a high level of androgens, and also there is an excess of LH release, and this causes an inversion of the FSH and LH ratio. The diagnosis is performed by the Rotterdam criteria, and the woman has to have two of the following three conditions. The first one is menstrual disorders, which can be anovulation or oligovulation. The second one is hyperandrogenism, which can be clinic, which means an increased body hair, which is called hirsutism, acne, or acanthosis nigricans. And this hyperandrogenism can be analytic, which will be determined by a high level of androgens in the blood. And the third condition will be a determination of the polycystic ovary. It means that there are a lot of follicles, small follicles in at least one of the ovary. Okay? Well, it's very important to treat a woman with PCOS because we know that she is in risk of infertility, but also women with PCOS are higher risk for obesity. In fact, 0.5% of patients with PCOS have obesity, and this obesity is related to insulin resistance, which this insulin increase in the blood, and it can provoke a menstrual irregularities. Okay. These women are also in risk of type 2 diabetes. In fact, 30 to 35 patients present glucose intolerance, and among them, 60% will develop a type 2 diabetes. Okay, so it's very important to control this kind of patients. They can also have a metabolic syndrome, which is a group risk of factors for heart disease and type 2 diabetes. Also, they can have a heart disease. They are in higher risk of a heart disease and high blood pressure. And the most important one, the most risky one, is the endometrial hyperplasia and endometrial cancer. Okay, this is a very, very, very small proportion, but they are in high risk of that. Okay. Well, this woman, as I told you before, they are in risk of anovulation. The main characteristics of the polycystic ovarian syndrome is the anovulation or oligonovulation. It means that amenorrhea means lack of periods or irregular periods, and this can lead to an infertility problem, and therefore these women often consult a reproductive clinic. Okay. The first treatment, the first step of the treatment is there is obesity, is weight reduction. Okay. Only a 5 to 10% of decrease improves biochemical characters such as insulin resistance and androgens level, and can reestablish regular periods with spontaneous ovulation up to 75%. Okay, so if there is obesity, or if it's very important to try to be on a diet or to consult an endocrinologist or a dietist. It's very important. Okay. If we are facing a problem regarding ovulation or ovulation, and we are looking for a pregnancy, it's important to look forward assisted reproductive technique, and we can use an ovulation induction such as clomiphene, gonadotropins, or letrozole. This can help the ovary to have spontaneous ovulations. Okay. If we don't want to get pregnant, the best treatment is the contraceptive pill or the progestagens. Okay. And if there is an insulin resistance, there is a treatment which is metformin. It is used for diabetic people, but in this kind of patient in polycystic ovarian syndrome, improves the insulin resistance and the hyperandrogenism, and also restarts ovarian cycles in 60% of the cases, and also favors weight reduction. So if there is obesity and insulin resistance, it's important to use this drug, but only if it's prescribed by a doctor. This is very important. Well, then we pass to the second pathology, and is the hyperprolactinemia. Okay, the hyperprolactinemia consists in an excess of production and secretion of prolactin. This hormone is secreted by the pituitary gland and prepares the breast for the milk production. It's very important that A third of women with amenorrhea, it means with absence of periods, have hyperprolactinemia. So women with amenorrhea, we have to rule out a possible hyperprolactinemia. Okay, if we face a woman with amenorrhea or with hyperprolactinemia, it's important to rule out some causes that can cause this increase in prolactin, which has some kind of drugs, okay, antipsychotics, neuroleptics, antidepressants, and hypotensives can cause hyperprolactinemia. So it's important to do a good anamnesis. Also, there are some situations that can increase a little bit the hyperprolactinemia, which is the sleep, the stress, also, of course, the pregnancy, and physical exercise can increase this hormone. And there are also the pituitary tumors, which are called prolactinomas. They are separated by microprolactinomas, which is prolactinoma less than 1 centimeter, and macroprolactinomas, which are over 1 centimeter of size. Okay, this can cause of hyperprolactinemia, and it's one of the things that we have to rule out if we see an hyperprolactinemia. And also there are other pathologies such as primary hypothyroidism and chronic kidney and hepatic failure that can increase this hormone. Well, the symptoms of hyperprolactinemia are irregular periods, and also the women can have galactorrhea, which is milk secretion by the breast. And if there is a macroadenoma, it means a big prolactinoma, the women can suffer from headaches and visual difficulties due to the chiasmatic compression in the brain. And also we can have symptoms of low FSH and LH, which are symptoms of menopause, such as hot flashes, okay, and dyspareunia. The diagnosis is made by a determination of the prolactin in a blood test. It is this hormone should be below 25 nanograms per deciliter, and if it's over than 100, it's important to discard a pituitary adenoma, so we will ask for an MRI scan. Okay, if this prolactinemia is high but is in the limit, okay, sometimes we have to repeat, because by repeating the test in a couple of weeks and asking for the woman to be resting at home, sometimes it will be a normal determination. Okay, and finally, the treatment for the prolactinoma, means for these pituitary tumors, are the dopamine agonists, which is just a pill. The better one is the cabergoline, which is called the Dostinex. Okay, this has been demonstrated that can reduce the prolactin and can restore the menstrual periods normally. Okay. If there is a pregnancy, the treatment must be stopped if there is a microadenoma, okay? But if there is a macroadenoma, this is a big prolactinoma at risk of chiasmatic compression, it's better to stay with the cabergoline, okay? Only if the macroadenoma is very close to the optic chiasmatic and has not been responded to the treatment, to the medical treatment, we have to do a transsphenoidal surgery done by a neurosurgeon. Okay. Well, then the third pathology, I will talk a very quick one about this one because it's not very common, but is a hormonal disorder. Okay, it's the congenital adrenal hyperplasia. Okay. This disease is caused by enzyme deficiencies, and the most frequent one is the 21-alpha hydroxylase, and this is an hereditary disease. Okay, it's produced by a deficit of the biosynthesis of the cortisol, which is a hormone, and this deficit increases the ACTH. This hormone produce or provokes a adrenal hyperplasia. It will be very increased in size. Okay, this hormone, the ACTH, stimulates adrenal androgen secretion, which inhibit the gonadotropin secretion and therefore can provoke infertility, virilization, and menstrual irregularities because the androgens increases. Okay, for the diagnosis, we simply do a blood test, and we will see that there is an increase in the androgen levels, such as the androstenedione, testosterone, and we can only see an hyperandrogenism, a clinic hyperandrogenism, and also we can see a woman with acne, with a lot of hirsutism, and this is very characteristic of this disease. And also we will see that there is a low cortisol, FSH and LH, and an increase in 17-OH progesterone. And for the treatment, it's very simple, it's only to use corticoids, okay? But it's very important because this pathology, of course, the prevalence is very, very small because it's a hereditary disease, but the treatment restore the menstrual periods and restore the fertility, okay? Then, regarding the thyroid disorders, okay, just take into account that hypo and hyperthyroidism can cause menstrual irregularities and can therefore decrease the fertility. It's very important because if there is no treatment if we have a hyper or hyperthyroidism, it has been associated to an increase in maternal and fetal morbidity and mortality. On the one hand, the hypothyroidism can provoke a low sexual hormone binding globulin 11, and therefore we can have a low estrogen and testosterone levels, and this can cause a menstrual irregularities. Severe hypothyroidism during the first trimester can alter the neuropsychological development of the fetus. Okay, it doesn't alter the probability of pregnancy, but it can alter the development of the fetus, which is very, very important. So if there is hypothyroidism during the first trimester, it's important to treat with thyroxine. Okay, the ideal TSH level for the pregnancy is below 2.5. And on the other hand, regarding hyperthyroidism, on the contrary, that hypothyroidism can provoke a high SHBG level, and therefore we will have high estrogen and androgen levels, and we can have as well menstrual irregularity. A serious hyperthyroidism can provoke a high FSH and LH levels, and therefore we can have sometimes risk of anovulation. And during pregnancy, hyperthyroidism has been associated with preeclampsia, miscarriage, and intrauterine growth restriction. Okay, and the treatment, if we have hyperthyroidism, the treatment if we don't want to get pregnant is with the iodine, or if we are looking for a pregnancy, with antithyroid drugs. Well, and then another hormone which is getting more and more importance here in IVF is the vitamin D. Okay, the vitamin D is responsible for the intestinal absorption of calcium, magnesium, phosphate, zinc, and iron. Its deficiency is related to several diseases such as rickets, osteomalacia, autoimmune and cardiovascular disease, immunodeficiencies, infection, and neurocognitive disorders. But it also has a role in reproduction, and we know that because it has been demonstrated that the vitamin D receptor is present in the ovary, the endometrium, and placenta. It is also related to AMH. It has been demonstrated that the higher MRH, the higher vitamin D level. But they are controversial studies, but this is the fact. Okay, if there is deficiency, a severe deficiency below 20 nanograms per milliliter, we can have a decrease in the pregnancy rates. Okay, and what is important in polycystic ovarian women, if there is insufficiency, the treatment with vitamin D can improve insulin sensitivity, follicular growth, and menstrual pattern. Okay, and during pregnancy, the vitamin D enables implantation and stimulates antimicrobial activity. And if there is deficiency, it can be related to recurrent miscarriage, preeclampsia, gestational diabetes, and metabolic syndrome. Okay, so one of the most frequent questions that ask our patient is, do we have to supplement with vitamin D? Well, there are insufficient studies that indicate that vitamin D supplementation significantly benefits the results. Okay, but some reports argues that it can improve the weight, height, Apgar, and the hyperbilirubinemia in pregnant women with gestational diabetes and vitamin D deficiency. Okay, it's very important that the dose shall not be over 400 units. Okay, so only we will give vitamin D supplement if there is deficiency. If the vitamin level is okay, there is no benefit. Okay. Then, Here I will talk very, very quick because it's not the main the theme of the presentation. But if we ask for basal hormones and we see that our patient has a low AMH and a high FSH, it's important to understand that probably we are facing to a low ovarian reserve or a premature ovarian failure. So it's very important to advise this woman to look for assisted reproductive technique or to preserve their fertility. Okay, normally the low ovarian reserve is related to age. The older woman, the lower amount of eggs, but in younger women, it's important to rule out some genetic disease, also autoimmune disease, environmental factors, cancer treatments. Some cancer treatments for the leukemia or breast cancer are gonadotoxins and can decrease the ovarian reserve. Also, the ovarian surgery for a cyst or for the endometriosis can provoke a low ovarian reserve. So it's very important if we see that is a high FSH, it's important to plan this kind of patients because probably will face a low ovarian reserve. Good. And finally, just to a quick view for a chronic stress, okay? The stress, not the acute stress, but the chronic stress provokes a high amylase and cortisol level, and this has been demonstrated and can alter the ovulation and seminal quality, and therefore provokes infertility. Okay, so I know that most of our women has, we are faced a story of infertility. They suffer from stress. That's I think 80% of our patients suffer from stress, but it's very important to support them. It's important to offer them sport, yoga, meditation to help them to decrease this stress, because it can add an extra disease to their problem. Okay, and also just to ending this presentation, the BMI disorders. Okay, it's very important to start a treatment or to start looking for a pregnancy in having a correct BMI. Okay, the anorexia, strict diets, excessive sport can provoke an hypogonadotropic hypogonadism, okay, and this can lead to amenorrhea and therefore infertility, okay. And the same as obesity, the obese women have a higher risk of insulin resistance, and they have an increased risk of probability of polycystic ovarian syndrome, and this can decrease the ovarian and sperm quality, and also it can increase the miscarriage rate. So it's very important to regulate the BMI. Okay, and that's all. I think I'm done. So it's very important in the first consultation to ask for the basal hormones. If there is something wrong, just to try to treat it and try to increase the probability of pregnancy.
And wonderful. Thank you so much for that presentation, and of course for explaining all those little things here. And well, as you can see, it has started. Lots of questions are here, and lots of questions I'm sure will be coming here as well. So I guess let's get through them. Okay, there's quite a lot of those questions. So let me go with the first one. I had high prolactin level, and now taking cabergoline weekly, my prolactin dropped to 4. Is it not too low? What is the best level for fertility?
There's no best level. If it's below 20, it's fine. I mean, so it's perfectly done with the cabergoline, so don't worry. And also, the best level is not there is not a standard level. The correct level is if you have normal periods with the cabergoline and with this level of prolactin. If you have restored your menses, I mean, everything is fine. So don't worry.
Excellent. Thank you so much, Margie, for the very first question, and of course for your answer. And let's go to the next question, actually from Margie as well. My testosterone level is 0.17. What is the best level for fertility?
That's a good level. Okay, but of course, just only one determination. It should be put in a context. We should take into account the testosterone level, the DHEA level, also the estrogen level and progesterone level. Okay, but this level is okay. If it's, I mean, a low testosterone doesn't mean a lot of things. It will be worse a high level of testosterone. A high level of testosterone, it can provoke anovulations. Okay, so this level is okay.
And excellent. Thank you so much once more. Okay, let's have a look. Next question. Why do I get hormonal imbalance, severe itching?
Hormonal severe itching. Thank you, Lisa. But normally, severe itching can be provoked by an excess of androgen level. Okay, this because sometimes it is called. Sometimes there is acanthosis nigricans, which is an accumulation in the skin of androgens. Okay, it can be itching, but as far as I know, sometimes the severe itching can cause by an excess in vitamin, okay, an excess in folic acid, an excess in vitamin D can provoke hypervitaminosis and can provoke itching. So I don't know if is that your case, but I would like to ask for a hormonal blood test.
All right. Thank you so much again for yet another question, Lisa. Okay, let's have a look. Next one is up. So my DHEA dropped from 4,400 to 3,200 within 3 months. What can be the cause? What is a good DHE level for fertility? How can I increase my DHE without taking supplement drug, only with food or something else?
Okay. So with food is, I mean, this level, it's okay. It's perfectly okay. Of course, if it's important not to only take only one value. Okay, it's important to take in the context. Okay, if your DHEA is 3,200, but your estradiol is completely is very, very low, it means we have an excess in androgens. Okay, but if your estradiol is in a correct level, it means that everything is fine. Okay, and then it is important also to check for the context. If you have a polycystic ovarian syndrome, it is better to regulate the androgen level. Okay, but if you have correct menses, if you are not obese, okay, and you have regular periods, everything will be fine. Okay, we don't have to be very, very crazy about level, which is the best level of hormones. Every patient is different. Every people is different. But of course, the DHEA, okay, the DHEA is we only ask the DHEA if we suspect a polycystic ovarian syndrome. We don't ask in a routine basal hormones. Okay, and the DHEA, we prefer also the testosterone to the DHEA. Okay, because the DHEA sometimes it can be during even in the same week can be very, very irregular. Okay, so it's fine. This level is fine. It will be, if it's more than 5,000, probably we will use the contraceptive pill just to decrease this level. Okay, and to restart a treatment for fertility.
And excellent again. Thank you so much for this. And let me go to the next question. So, is there a reason why TSH status would surge from 0.26 to 20 within 4 weeks, also during stimulation for IVF?
Yeah. So it has been demonstrated that sometimes the IVF, I mean the treatment with FSH and HMG, and the high levels of estrogens that can provoke the IVF can disturb the levels of TSH. Okay, we have to take into account that TSH receptor also, I mean, is very, very similar to the FSH receptor. So sometimes if we have a hormonal imbalance during IVF, the TSH can be very, very variable. So yes, it can be normal. And if it's 20, of course, after the IVF treatment, before the embryo transfer, it should be regulated prior to the embryo transfer, for, as I told you before, to avoid a potential neurocognitive problems in the fetus.
Okay, again, thank you so much for yet another explanation. And let's have a look at the next question. Just give me a second, because there are two parts of it. I need to show you the first one from my TSH goes between 0.68 and 1.04, and my T4 is 9, which is low.
No.
And let me just go to next part. We use donor eggs as I have low AMH and damaged tubes from pelvic inflammation disease.
Okay, thank you, Gemma, for your question. This level of TSH is completely normal, okay, and T4, so don't worry, because this is completely fine, okay? As far as this below 2.5 and 0.68 is a correct level, so don't worry, it's fine. You don't need any medication.
Okay, and just give me a second. I'm still checking. Oh, okay, sorry, there is one more part. Apologies, I missed that. So yeah, could this have caused failed implantation and miscarriage after seeing heartbeat at 7 weeks?
No. It has been demonstrated that the low TSH, which is not your case, can provoke sometimes menstrual irregularities, but is not related to implantation failure and miscarriage. It's only the problem with the hypothyroidism or hyperthyroidism is that it can provoke a neurocognitive disorders in the fetus. It cannot provoke miscarriage. Okay, so this is very important to take into account. Okay, so if we see that there is a miscarriage, of course, everything should take into account all the hormones, but this is not a frequent cause of miscarriage.
There is a follow-up. They say maybe pituitary disease or something.
Pituitary disease is a multifactorial entity. Pituitary disease can provoke a low TSH, low prolactin, low FSH and LH levels. So I don't think that would be that case. I mean, if there is a miscarriage, we have other things that are most important, such as, of course, the embryo, the thrombophilias, the uterus, the fallopian tubes, more than the TSH levels.
Okay, and one more thing from Gemma. Okay, I have been told T4 should be above 12 in UK.
That's not. I mean, it doesn't need to be that. In fact, here for IVF, it's the most important thyroid hormone that we have to take into account is the TSH. If the TSH is okay, we don't need to ask for the T3 or T4. And we are over-treating sometimes people without the risk.
All right, understood, of course. Thank you so much. And let's have a look at the next question. I have been diagnosed with Hashimoto with high TPO levels. I am currently taking levothyroxine to get my TSH levels close to 2. What other treatment would you recommend with thyroid antibodies to increase implantation chances?
Okay, so of course, if you have been diagnosed with Hashimoto disease, you are in risk of hypothyroidism during pregnancy. So the best treatment as you are taking is the levothyroxine, okay, which is the most important thing. Then, if you want to increase your implantation chances, of course, there are a lot of things that influence the implantation, which is we have already done a webinar regarding this. Of course, we have to take into account the embryo, if it's a normal embryo, chromosomic normal embryo, the quality, of course, the uterus, to check the fallopian tubes if they are okay or is there any pathology. So there are several factors that affects the implantation. The TSH levels are not a factor. It might affect a little bit, of course, if there is a severe hypothyroidism or a severe hyperthyroidism. Okay, but if you are already in treatment, don't worry, because it won't be your case. It's more important to check the uterus, the implantation area, the endometrial cavity, and also the fallopian tubes, the embryo transfer, mean to perform a correct and perfect embryo transfer. This is the most important factors for the implantation.
And yes, yet again, thank you so much.
You.
Okay, now we will discuss vitamin D. In simple terms, can you describe which food and quantity of each food that you mentioned a pregnant woman ideally needs per day?
Well, the pregnant woman will benefit the best vitamin D generator is the sun. Okay, so if we sunbathe a little bit, half an hour a day, of course, we depend in which country we are living. This is the best source of vitamin D. Of course, there are some foods such as of course, milk, cheese, and also vegetables. In green vegetables can offer a good proportion of vitamin D. Okay, but I don't know really. I think it will be better to ask for a midwife probably. I don't know which quantity of food you need per day, but I mean a normal diet, a completely normal diet with vegetables, not to abuse of red milk, but a complete diet, a correct diet will be okay. So you don't need to do a strictly specific diet, of course, to avoid. You have to avoid roast meat, to fish. Okay, fish you can not to. It has to be cooked. Okay, so there is no very specific food that is better to take.
All right. Again, thank you so much for that question. And actually, sorry, there is another question on the vitamin D. So is there a difference getting it from the sun compared to getting it from supplements? What is the best way? How long should we stay?
Okay, so if your vitamin D level is correct, okay, you have to, if you take from the sun, that's perfect. If you suffer from a deficiency or insufficiency, it is better to have a vitamin D supplement because the dose is higher. Okay, so if you have below 20, it's better to take vitamin D, the cholecalciferol, which is the precursor of vitamin D. It's better to take that because the dose is higher, and you will restore your vitamin D will be restored quickly.
Okay, thank you so much again for that. And so, would you recommend supplementing DHEA for someone with high levels? Can it be beneficial to supplement and go above the recommended range? 43 AMH 0.5.
Okay, yes. I will recommend, okay, because if your AMH is 0.5, I mean, if you have a low ovarian reserve, it means that your androgen levels will be lower, because sometimes the androgen level is very increased in the polycystic ovarian syndrome, means with people who has a lot of follicles, and therefore an AMH, a higher AMH. So probably if you are, of course, we are not facing a congenital adrenal hyperplasia, of course, I will recommend you to supplement with DHEA, because it has been demonstrated that a testosterone supplement can activate the dormant follicles, and therefore can increase the number of follicles for women with a low ovarian reserve. So in that case, yes, probably you can benefit of taking the DHEA.
And excellent. Thank you so much. Okay. And what about melatonin during stimulation to improve egg quality and egg maturity?
Okay, there are controversial studies. Okay, for example, in our clinic, we used to recommend it. Okay, we used to give a vitamin, a complex which contains melatonin as well, because the melatonin improves relax. Okay, so it benefits the sleep, and when we are sleeping and when we are relaxed, the body restores. Okay, the brain relaxes and the brain can rest, and therefore the quality, and we will feel better, and the quality of the egg can increase. So in that case, yes, it will, and of course it won't harm you. So I think that I'm pretty happy to this use.
All right. Again, thank you so much for that. And let's have a look at the next question. So, how can I drop my glucose level? I have the feeling it is too high, 94 milligrams per liter.
Okay, it depends of this level. This level depends if it was a basal glucose or if it was after glucose ingest. So it depends. It's not extremely high, I have to tell you. Okay, 94 is not extremely high. I think it's a normal level. But if it's only a simple determination, probably you have to repeat it in a couple of weeks. Okay. And if it's still high, of course, we can recommend the metformin. Okay, the metformin can restore the glucose level, but only if there is in a context of infertility or in a context of overweight.
All right. Again, thank you so much for that. And next question. I don't have thyroid issues. Is it possible to get a surge of LH if FSH is high? If showed peak on fertility monitor, I would presume I'm ovulating, but that may not be the case.
Okay. If the FSH is high, okay, it means that probably your ovarian reserve, I mean, depending on the levels, okay, if there is your FSH is high, it means that the ovarian reserve is very high. Is low, okay, but it doesn't mean that you are not going to ovulate. Of course, if you have periods of amenorrhea, it means that your ovulation will be very irregular. So sometimes you won't have LH surge, okay. But if you had any a period, it means that 14 or 17 days before there was a late surge, okay. Of course, we can monitor in an ultrasound scan, or you can monitor by late sticks, okay. So if FSH is high, it depends. If your FSH is over 15, means that you are your ovaries are premenopausal, okay. So it's probably you won't have periods in a period of time. But if it's a high FSH over between 10 to 20, it means that your ovarian reserve is decreasing, but it doesn't mean that you won't have periods, regular periods. Okay.
And again, thank you for yet another question, and of course for your help. And let's have a look at the next one. So does SHBG vary from prolactin level? My value dropped as my prolactin dropped. What is it for?
Okay, so the sexual hormone binding globulin is a hormone that it is used to bind the hormones, okay, to bind the androgens and to bind the prolactin. Okay, it's a hormone that if, for example, I don't know very much how to explain, but it's like a carrier. Okay, if the prolactin, when there is a prolactin, the prolactin goes, its action is it's through the sexual hormone binding globulin. Okay, when the prolactin is fixed to this hormone, it can do its action. Okay, so if the prolactin drops, the sexual binding hormone drops because it's close to the prolactin, is attached to the prolactin. So it's completely normal if the prolactin level decrease, that the hormone binding globulin decrease as well. Okay, but is here for an IVF is not very so important, this determination, okay, only in the context of a polycystic ovarian syndrome. Okay.
Oh, of course, again, thank you so much for that. And let's have a look at the next question. There are a few questions left, okay? So, of course, if you have any more questions, you know what to do. Go ahead and do it
Of
now.
course.
And let's have a look at the next question. I understood
Mhm.
that Vidman, sorry, not sure here, without fallopian tubes can be successful with IVF treatment.
I undertook that
Understood,
we.
understood,
Uh,
sorry, understood.
I- I'd say that with men without, so I suppose it's women without fallopian tubes can be
Yeah,
successful with, of course.
right.
Of course, I mean, the fallopian tubes they serve for the in vivo fertilization, for the spontaneous, for natural conception. If there is no fallopian tube, of course, we cannot. We need, it is mandatory to perform an in vitro fertilization and to do a trial, an embryo transfer to put this embryo inside the uterus. So, of course, in fact, is one of the best prognosis in IVF, on the tubal factor. Yes.
Okay, wonderful. Thank you so much. All right, and Margie has added one more. Because of iron deficiency, I'm taking ferrocru
Okay.
iron drug as ferric maltol. Could it affect my hormone level?
No, I mean, if you are taking iron and you are already taking it and your iron levels are okay, it cannot affect your hormone levels. Don't worry. Of course, the iron is very important, and it's more important during pregnancy, because during pregnancy the requirements of iron will increase, and therefore the hemoglobin can decrease. So, but it cannot. The iron deficiency is not related to infertility and to implantation failure. Of course, severe anemia. Of course, we see there is a severe anemia. People will feel very, very, very tired, and of course, there is not an optimum atmosphere to getting pregnant. Of course, everything we have to restore everything, but it has not been related. The iron deficiency has not been related to infertility.
All right, again, thank you so much for yet another question, Margie, and of course for your help.
Okay.
And let's have a look. Okay, more questions are coming in. I am interested in gynecology and in vitro fertilization. Does thyroxine have any role in embryonic myogenesis or HCHR genesis?
Okay, thank you, Dalina, for your question. Currently, I'm not very familiar for a ACHR genesis. Okay, that's an interesting question. I will look that. I will talk to my colleagues, but I'm sorry, I cannot ask you for that, because as far as I know, the thyroxine, it doesn't imply in embryonic myogenesis. I don't know. Okay, so I don't want to give you wrong answer, but it has been demonstrated that the thyroxine, of course, it's very important for to restore, of course, the thyroid levels, the TH levels, and also it's important if there is a correct TH level, because during the pregnancy the TSH level can increase, and sometimes they are in risk of hypothyroidism, and this can affect the fetus. Okay, but I don't know if there is studies with thyroxine regarding embryos. So it's interesting, and we will search.
Of course, understood. Again, thank you so much for that. And okay, let's have a look.
Mhm.
And the next question. So I had my egg retrieval yesterday doing egg freezing
Okay.
only. Can retest my hormone levels this week, or is it too soon? Which hormones is it okay to test right after egg collection?
Okay, so Patricia, I hope everything was fine, and I wish you all the best and good luck. Okay, will be too soon. Okay, if you had your egg collection yesterday, probably now your progesterone level will be very high because you have ovulated, and also your estradiol levels will be very, very high. So it's important, if you want to check your hormone levels, it's important to wait at least your first period after the egg collection. Okay, and the hormones will be the estradiol, the progesterone in the luteal phase, and the anti-mullerian hormone, and also if you want to check your androgen levels as well. But the most important one is the estradiol, FSH, P4, and AMH, and prolactin as well.
And excellent again. Thanks so much for that. Okay. And Lisa has added, is there a medication that I can take to regulate my hormones?
Because this is a very general question, okay? It depends on which hormones, okay? It's very important. You have to understand, everybody, that if you want to take any vitamin supplement or any treatment, it's important to understand why are you taking, okay? We have to take only if there is any alteration. If you have hyperprolactinemia or high prolactin, of course you have to treat it. If you have vitamin D deficiency, of course you have to treat it. If you have TSH alteration, you have to restore. So only take medication to try to increase the chances for a pregnancy. That's not the point. And sometimes if you take a lot of vitamins or a lot of supplements, it can be worse, and you can damage yourself. Okay, so if you want to check, you are during the first consultation, it's important to ask for basal hormones. If these hormones are okay, perfect. It means that everything is fine, and probably we only take vitamin supplements, but only folic acid. Okay, melatonin, is that the case, and all the vitamins that can increase the oocyte quality. But the TSH level, the prolactin, and these all the hormones that are important, if they are okay, you don't have to take any medication for that.
All right. Again, thank you so much. Okay. Next question. Hello. Would you recommend a woman should continue taking lutein progesterone injection beyond 12 weeks of pregnancy in an IVF patient?
Okay, so it has been demonstrated that to maintain the progesterone over 12 weeks is not necessary. Okay, in fact, it has been demonstrated that the progesterone is needed once we can stop this progesterone once we see a heartbeat. Okay, but we prefer to maintain until week 12, just to be completely sure that the corpus luteum, or that the placenta gives a correct level of progesterone. Okay, so if you want to take it, of course you can take it. It won't be damaged, but it is not necessary to have a progesterone supplement over 12 weeks.
All right. Again, thank you so much for that. Yet another one. And what can I say? Always so helpful. Okay, let's. We will be slowly finishing. Okay, there are like a few questions left, but of course, remember that if you would like to ask anything, you can still do it now. But also, if you wish, you can definitely get in touch with Dr. Alejandra, her team at Juana Crespo, and I'm 100% sure that they will be happy to help you out and answer any of your questions as well. And let's have a look. Margie has added, I tested my AMH level 1 year ago at 39. How fast does it drop within a year? It is scary to test again.
Yes, so unfortunately, the AMH level drops within a year, and after the age of 38, even every 6 months, we can have a drastic drop. Okay. Of course, you don't have to be scared. Okay. In fact, I prefer to check the antral follicle count, okay, better than the anti-mullerian hormone, because sometimes we have people with a very low anti-mullerian hormone, and then we do a correct stimulation, and we can have more eggs than we expected. Okay, so we will never discard the patient just by taking into account her AMH. Okay, but yes, it can drop within a year. Okay, from 30 to 35 years old, this drop is not very significant, but after the age of 37, yes, this drop can be dramatic. Even in 6 months, it can drop a lot. Okay, but don't be scared about that, because don't be scared if your AMH is low. Of course, it will be low. It means that your ovarian reserve will be low. But if we do a correct stimulation, if we perform an IVF and we get at least 2 beautiful embryos, your probability of having a baby is high.
All right. Thank you so much also for the encouraging words. I definitely think that most of women, when they are checking it, they are kind of freaked out, but
Yeah,
it's normal. But yeah, thank you for that. And
you're
let's have
welcome.
a look. Okay, next question is up. Could a hormone imbalance be the cause of repeated implantation failure?
Okay, so of course it can be the cause, but we have to take into account that sometimes the hormonal imbalance is also inside in a context of a lot of things. Okay, it's not only the main cause. Okay, sometimes we have a polycystic ovary syndrome and therefore we have a hormonal imbalance. Okay, in repeated implantation failures, of course, there are some tools and we have some causes that it's mandatory to check before a hormonal imbalance. Okay, but of course, it's important to check the hormones. That's sure, and of course, this webinar is for that. But it's for implantation failure. Of course, the 75% of the causes of implantation failure is because of the embryo. If the embryo is not good quality or is a chromosomal abnormal embryo, of course this would be the cause of a no implantation. Okay, so we have to take into account the embryo. We have to take into account also the uterus, the uterus edges. Okay, and now we are seeing the edging of the uterus, and it is not the same. It's not the same a uterus, a 42-year uterus than a 30-year-old uterus. Okay, so it's important to check the uterus, to check the implantation area, to check the endometrial cavity, the endometrium as well, the thickness and the appearance of the endometrium, also the thrombophilias. Okay, it's very important to rule out any possible thrombophilias, also any immune causes of implantation failure. And of course, once we have ruled out all these kind of things, it's important to check all the factors such as hormones. Okay, but need to take everything in common, not only the hormone imbalance. So in your case, if you have repeated implantation failures, it's important to go step by step and to focus in the main areas, in the main causes of implantation of implantation failures. Okay.
Amazing again. Thank you so
Thank
much
you.
indeed. And yeah, we will be slowly finishing. There are like two questions or one question, sorry, I
Perfect.
believe. But let's have a look. Okay. What kind of hormonal stimulation strategies are there for egg retrieval?
So we have a lot. So this can be the theme for another webinar. Okay, it depends. We have a lot of strategies. I mean, for example, in our clinic, I cannot tell you because our treatments are personalized. Okay, we do strictly personalized treatment. So it depends if the woman has a low ovarian reserve. Probably will focus in a kind of a type of stimulation. If there is a polycystic ovary, it's very important to stimulate correctly the polycystic ovary, because as they have a lot of follicles, okay, it's important to make a balance. Okay, because if we use very slow doses of hormones, probably we will have a low responder, a poor responder, and we will have a bad result. And on the contrary, if we use if we stimulate with very high doses of hormones, probably will have hyperstimulation syndrome, and of course the oocyte will be in a bad quality. So it's very important to have a balance. Okay, it's different to stimulate a polycystic ovary than a low ovarian reserve. It's different to stimulate a tubal factor than a woman, an older woman. So it's I cannot tell you what is the stimulation strategies, because it depends. It depends on characteristics of the patient, depends on the ovarian reserve, of the age, of the results of the previous cycles, and also of the characteristics of the patient. So every patient is different.
Thank you so much. And yes, I
Thank
believe you
you.
are very right. We could spend another webinar
Yeah.
on that. But thank you so much for giving those tips here as well. And
Thank you.
yeah, we will be slowly finishing. I think that was our final question. So thank you so much, everyone, for so many questions. I always
Thank
love
you.
it when you ask so many questions. And we are definitely happy that we are able to help you out. And yeah, Dr. Alejandra, what can I say? It's always a great pleasure to have you here.
Thank you.
And I can only mention and show you a few things that our patients would like to say. And
Thank you
as you
very
can
much.
see, thank you very much for this excellent
Thank
webinar,
you.
sharing your knowledge. Very helpful, insightful. Thank
Thank you,
you.
Patricia. Thank
And
you very
thank
much.
you so much for taking your time, and we
Thank
really
you.
appreciate it. Couldn't agree more, really. Thank you so much. And as you can see, more and more of
Thank you
those
so
thank yous
much.
are coming up.
Thank
And
you so much. It's a pleasure for me.
definitely. It's also a pleasure to have you here back with us. So I know that it is just one of those webinars, and we will have more of the webinars with you. So I'm already looking forward to it. Thank you so much. And I just also want to mention, remember, it has been recorded. So of course you will have a chance to watch this. You can go to our website, My IVF Answers, and you can find over 300 webinars. So go ahead and do it. There are so many topics. I'm sure you'll find it interesting. And as you know, we will be back here tomorrow at 8 p.m. UK time, and we will be back also the next day, etc. So I do hope to see you here, because I'm sure you have plenty of questions to ask. And if you go to our Facebook and Instagram, you know that there are lots and lots of many different topics coming up. Once again, thank you so much. It's always great to have you here, and I do hope that you will all have now relaxing evening, and Alejandra as well. Thank you
Thank
so
you so
much.
much.
Anything else you would like to add?
Thank you. It was always a pleasure for me, and I appreciate this kind of question as well, because for me it's always important and to keep me investigating and keep me researching. So I appreciate that very much, and thank you so much.
Thank you. Indeed. Take care, everyone. Thank you. Bye.
Bye bye. See you soon.
Bye.